Really, when we talk about sarcopenia, we're talking about that age-related muscle loss. Sarcopenia is the main driver of frailty. It's the main contributor towards patients losing their independence, perhaps aside from, trauma-related things like hip fracture. Sarcopenia is really the thing that's driving a loss of independence with people as they age. And over the last decade, we've become much more aware of how impactful the loss of lean tissue is on so many other health outcomes that we're very interested in, like cognitive function and metabolic health. So my goals today is to do a brief review of the assessment of sarcopenia so that you understand what you're looking for in your office. I do make a slight modification to the current recommended guidelines because I think we can do better than what's currently recommended for screening sarcopenia. We're going to talk a little bit about protein, and we're going to talk about the supplements for sarcopenia so that you leave here today knowing who does fish oil work in, why do BCAAs not work in every patient, how long do people need to take creatine before it starts to show benefit, so that you have a lot of confidence in prescribing in your patient population. So there are some inherent challenges with researching sarcopenia, and I think this lends to some, frustration and maybe even conflict in the way we talk about lean tissue. If you've ever spent any time on Instagram or TikTok, you'll definitely see that there's lots of differing opinions about the importance of nutrition, exercise, and supplements when it comes to muscle mass. When we're talking about sarcopenia, it's a unique population. We're not talking about 22-year-old weightlifters who, can eat grilled cheese and grow muscle mass and maybe who don't need any additional supplementation. We're talking about an aging population that has underlying metabolic disease or maybe has increased visceral adiposity and a loss of lean tissue. These are the patients that have the room to grow and the room to benefit when it comes to intervention. So if you've ever felt frustrated reading information about or literature about protein intake and resistance training and the impact that has on muscle growth, it's often because we're talking about a younger population, and this is really a conversation for our aging population. We also don't have great staging criteria for sarcopenia. You kind of either have it or you don't, and that also makes it challenging for us to know how helpful we're being with our patients. If your patients went from being, having sarcopenia to having a little less sarcopenia, are we happy with that clinical outcome? In research, sometimes we're not that happy when things don't change that much. Whereas if we look at your patient, if we preserve some of their muscle mass, we maybe can have tremendous outcomes and impact on their lives. So definitely some difficulty and challenges with just even researching this topic, which I always like to start with, because sometimes we come into these conversations not fully understanding the scope of the research or why it's so hard to study. This is a hard thing to study, and we'll talk about it, especially as we get to the protein section. So interestingly, all conversations about sarcopenia right now say that we need a multidisciplinary approach, right? We need people who are experts at psychology and behavior medicine and change, right? Because we need our patient to do a thing in order to treat their sarcopenia. We also need people who have expertise in nutrition. We also need to be able to support people with exercise and also with supplementation, I'm going to say, in this population. We currently have no drug therapy for sarcopenia, although they are looking at like certain molecular targets for drugs. We really don't have any drug-based therapies for sarcopenia. So prevention is really where it's at, which we'll talk about in a second, but also we're talking about nutrition, exercise, and supplements as being the number one support that we can offer these patients. We also know that sarcopenia begins decades before we originally thought that it did, and so an interventional approach in people that are much younger is important. And the definition for sarcopenia has changed a little bit over the last couple of years. It's actually much more of a valuable definition for us as clinicians, because testing muscle mass with a DEXA may not be accessible to you. And in the past, we kind of assumed that people needed to have scans or we needed to assess their lean body tissue in that way for them to be diagnosed with sarcopenia, where now the definition is actually much more about muscle failure. So loss of muscle strength and function and muscle failure. That's a much more functional diagnosis for us and easier to apply in clinical practice. So I'm not saying you don't ever measure your patient's muscle mass, but you can start to raise suspicion about sarcopenia when we start to see weakness and other signs of muscle failure. So these are your definitions for sarcopenia based on the European Working Group that's looking at this as a particular clinical guideline. You can see that low muscle strength is now dominating the discussion versus us waiting for a BIA test or a DEXA test that tells us about actual muscle mass. These are your screening tests, and I'm not going to go through each of them. The SARC-F I've put right in the slide deck. So if you're not using this in clinical practice, it's a very easy assessment. It's intended for the generalist to deliver to their patients. But there are a couple of other functional tests that you may benefit from administering in your patients, especially if you're really closely monitoring their progress. When you'll see as we get to the interventions, we have research that things say like fish oil improve hand grip strength, which is a marker of frailty. We may want to be measuring these things at baseline in your office so that you can actually track if it's getting any better when you add it. I put in there that BIA testing, I called it an affordable solution. I mean, it's affordable compared to MRI, but having a BIA machine in your office, especially if you deal with this patient population, you may benefit from that as an investment as a clinician because it tells us so much about supporting this patient population. I put the SARC-F screening tools for you right here in the slide deck so that you have it as well as the scoring. So this is the current guideline recommended for clinicians to investigate patients with sarcopenia. I've made a very strong recommendation for how we deviate from this. So something you'll notice about this conversation is that if you're suspicious about sarcopenia, you act. But if you're not suspicious about sarcopenia, you just send the patient on their merry way and we don't talk to them again, right? I think as preventative medicine specialists and as integrative practitioners, we can do a little better than this. And my recommendation for how we navigate this is that even if patients are in their third or fourth decade, but they do not show signs right now of sarcopenia, that we're still talking about prevention and we're still screening patients for the very things that will propagate the development of sarcopenia, like a lack of resistance training and a lack of protein intake. So just to differentiate again between those two things, the current guidelines suggest if we're negative, we just reassess them at another time. I'm going to suggest that if your patients are in that third, fourth, fifth decade and they don't show signs of muscle loss in this moment, that we still talk to them about nutrition and we still talk to them about resistance training. Hopefully, we all agree that that's the right approach, since we know that sarcopenia is starting decades before it becomes a clinical manifestation. We also have this overlapping challenge of obesity with sarcopenia. And so hopefully you're familiar with that term, sarcopenic obesity. And this can get masked, especially in an older population who's used their crude weight as a measure of health. And they say, I'm sure we've all had those patients that say, I'm the same weight as I was 20 years ago. But if we ask them about the shape of their body or where they carry weight, it's changed over those 20 years and they've lost appendicular muscle mass and gained visceral adiposity. So crude weight is not a great way for us to determine body composition. Sarcopenic obesity is when patients have a rise in abdominal adiposity or visceral adiposity and a loss of muscle tissue. And that patient is the patient that actually fares the worst out of this trifecta of these three patient populations. The reason that I'm calling this out is because you as a clinician might see things like bone mineral density land in your office. And we may want to use that as a proxy for frailty, right? Like, do they have bone loss? If they don't, maybe they're fine. But interestingly, patients in larger bodies and patients with sarcopenic obesity may have a higher BMD than we expect, right? Their bone mineral density may not be low. We don't want to use that as a proxy for future frailty because if they have sarcopenic obesity, they will be on a path towards frailty, even if their bone mineral density has stayed relatively constant. I just wanted to make sure that we were aware of that because sometimes a BMD lands in your office and you have that test result, even if you didn't order it. I do also want to make a mention of acute sarcopenia. I bring this up a little later in the presentation because a lot of the tests and studies that we've looked at from an interventional perspective are looking at bed rest. So if we put a patient on bed rest, what happens to their muscles, right? And even as little as like 7 days of bed rest, we have muscle loss, like almost at every age and stage. And I think clinically, we can imagine that there's moments where people would have quote unquote bed rest or disuse of their bodies and of their muscles. And so acknowledging that even as little as 7 days of disuse does cause a loss of muscle mass. And there's some really great examples I have later in the presentation on how we might consider using things like leucine and fish oil in patients prior to surgery, especially if we know we're going to have like bed rest or disuse after that surgery, because this population is so at risk for muscle loss and it's so easy for us to lose muscle and then very difficult for us to try and recover it. We may want a more preventative approach for patients who have been put on bed rest for various reasons, even if they're medical reasons. Okay. So let's talk about interventions and talk a little bit about protein. We're going to cover protein, leucine as a branched chain amino acid, HMB. We're going to cover fish oil and we're going to cover creatine. And in depth, hopefully by the end of the presentation, you really understand the difference between who benefits and who doesn't benefit from those nutrients. There's generally a theme across all of these nutrients, and it's really about baseline status, and it's about whether or not they reliably are hitting the requirements of protein intake, whether or not they benefit from additional support and additional supplementation. So that's kind of the overall theme. So if in the future you ever see a study that's like the fish oil didn't work, you have to ask yourself the question, like, what was the nutritional baseline status of this population? And when we study a malnourished population, sometimes we can assume that we don't see these patients in practice, right? And we would say, well, my patients aren't malnourished. But the vast majority of patients in an elderly population are not meeting their protein requirements or their fatty acid requirements. So no, they may not be quote unquote malnourished, maybe compared to a low resource country or a low resource area. But in theory, this entire aging population does have difficulty meeting those nutritional needs for those two very nutrients that we're concerned about here. So your patients probably are under the recommended daily intake of those nutrients. And sometimes when we study these nutrients in a younger population, we see no benefit because they don't have that gap as far as nutrition intake goes. And we don't need to support those patients. They're fine. Okay. So here, this is my very terrible drawing. I actually joke in the Confident Clinician that I have two left sides of my brain, that there is no right side. This is about as artistic as it gets. But I wanted you to see this like general trend of evidence hierarchy around protein and resistance training when it comes to sarcopenia. So we have to remember that like our patients are on a bit of a health behavior change journey, and wherever they are on the day that we meet them, they probably have room for improvement. And wherever they fall along this line, the next step up is going to be where to place focus. So if your patients have like no protein intake or below the goal and no exercise, any amount of protein and exercise is going to help. Again, we see that in research where we study, say, institutionalized elderly. If we feed them anything, they get better, right? If we feed them like a bowl of yogurt every day and we do chair yoga, they see improvement in their muscle mass and their reduction in frailty. That doesn't mean that yogurt and chair yoga is the best solution. It just means for that population, it moves them up a notch and improves their muscle mass. We then see improvement with protein adequacy, but what you'll see very quickly is that protein adequacy alone does not increase muscle mass in the elderly. We need to combine it with resistance training. However, if people are chronically below that recommendation, they will have loss of muscle tissue. So we at the very least want to get them up inside that range. Resistance training on its own improves things. So even if people don't eat enough protein and they do resistance exercise, they see improvement. Obviously, resistance training plus protein is the best. And so you can see that we move up that sort of evidence hierarchy depending on what we're talking about. And that's quite important to remember because, again, often we'll hear about people that are trying to optimize components of their health, and there's no benefit to doing that with certain interventions. We're talking about like a generally underfed group of people and under-exercised. So anything we do really supports that muscle loss. So we got some great and recent data. This one was published in December of 2024. Very big population studied in this one. And they looked at various tertiles of protein intake and looked at muscle function, looked at muscle mass. And so there was a clear differentiation between the people who ate above 1.2 grams per kilo and the people who ate below 1.2 grams per kilo. Now, remembering that this is observational, but we're talking about something that develops over decades. And so this is actually quite good research in that regard. We want to watch people over time. And for sarcopenia, we don't want to watch them for a day and see if they have protein synthesis. We want to watch them over decades and look at their protein intake and how that impacts muscle mass. So you can see it made a huge difference in the male patients, but they really did make a big correlation between eating over 1.2 grams. And truthfully, the research has kind of always said this. If we go backwards in time, there's lots of other studies that say the same thing. But this was just the most recent. And because it was a meta-analysis, it's summarizing the research of many studies, 23 to be exact. And so it was a very clear differentiation along these lines. Below 0.8 was not good. 0.8 to 1.2, which sometimes that's where patients will shoot for, that still was not the best. And above 1.2 is where we saw the most benefit. Okay, this is another one that was looking specifically at the combination of resistance training and protein. And what they were trying to figure out was, is there a better kind of protein, right? Which that's always like the $1 million question. What's the best kind of protein that we can give our patient? And interestingly, I took their forest plot here for us to look at. What is really obvious is that the protein on its own, and so if you're unfamiliar, if it crosses this line here, then it was not statistically significant. So you can see that protein alone was not hitting statistical significance. Exercise alone was, which is kind of interesting. I said that earlier. This one I find really fascinating, and I can't explain it. My guess is that there's not enough studies on protein as peanuts as a source of protein plus resistance training, but they couldn't find significance. But things get better and better as we move up the scale, with soy and meat and milk protein all performing very well and improving both muscle mass and grip strength and some of those other markers of muscle function when they're combined. So I think that's a really important piece, because we often will focus on protein. I'm sure you are all experts at prescribing protein. You probably have a million lists of ways people can hit their protein targets. You kind of have to approach the prescription around resistance training as emphatically as you are prescribing their smoothie. Okay, so if you spend a lot of time talking about protein adequacy, you have to match that with a lot of time spent around resistance exercise, because improving protein adequacy on its own only takes you so far, and it's not going to give you that full benefit that we're looking for. We do need it to have, we need the substrate plus the tension, right? We need the substrate and the exercise in order for us to see the maximum amount of benefit for these patients. And I'm sure this is not new knowledge, right? Like, I'm sure this is something that you are aware of, but it's a good reminder that it's as important, right? Sometimes we can lose sight of like all things equal, what's the most important thing here? And it is as important to prescribe resistance training as the protein. So we want to spend lots of time on this. And I've made the note here around protein timing. I don't want us to get super lost in the details around when people eat protein. It's kind of one of those things that, like, if someone arrived at your office and they already ate perfectly, maybe you can talk about the timing of their shake post-exercise, but the vast majority of patients, if you think about my arrow there, really only need to take one step up on the arrow and eat enough protein and do enough exercise. But there is a little bit of extra evidence that post-exercise muscle protein synthesis is improved with post-exercise protein. Sometimes that's a great way to habit stack for patients, honestly, is to just have them do their protein after exercise. But the vast majority of patients are not even in a place to benefit from that because they're not eating enough protein. And that's really the place that we want to focus. I added some additional pieces here that are a bit outside the scope of today's presentation, but whey protein has some very positive insulin promoting pathways that I think we maybe want to leverage in our patients with insulin resistance. But choosing a protein, you can be quite liberal with how you choose protein for your patients. We just want to combine it with resistance training. Okay, so if we come down and talk about leucine, which is a branched chain amino acid, we do want to be mindful that not every paper on leucine as a standalone solution is positive. And I'm sure you've seen, like, we got really jazzed online about BCAAs, and then we've kind of changed our tune about that, and maybe nobody needs BCAAs. I don't think that's true either. I think that those two extremes are missing a group of people. The interesting piece here, though, is that leucine can't replace their protein adequacy. And I would never say, well, don't worry about your total protein intake. We'll just focus on this one amino acid. We certainly don't want to do that, right? But interestingly, patients who are under on their nutrition status, people who are not meeting those baseline goals, may be the people that benefit the most from leucine. And the most recent research actually suggests that it's that period of deconditioning or period of bed rest where leucine may have had a more positive effect than just protein on its own. So this was kind of a neat study that looked at the impact of, so they did resistance training, and I promise this proves a point. They did resistance training, and then the other group did resistance training plus a protein supplement. And in that protein supplement, they had, and then there was protein plus leucine. So there was resistance training plus leucine, and there was resistance training, and then there was a control group. And essentially, they put them through a 12-week training program, and they were trying to figure out how many patients still met the diagnostic criteria for sarcopenia at the end of the training block. And then when the training block was done, they took away all the interventions. So they took away the exercise, they took away the protein, and they tracked them going forward after they removed all of the treatment. And interestingly, at the end of those 24 weeks, the people who had done resistance training plus the protein and leucine had actually lost the least amount of muscle. Like the exercise had, the benefits of their exercise had been maintained after a period of inactivity. Now, sometimes these studies, like, that's a very contrived situation, right? You're like, when would my patient ever train and then stop training for 24 weeks? But you might be able to imagine a clinical applicability for this in a patient who, say, gets a new diagnosis and ends up having to miss their exercise, or who is bedridden because of a surgery, or who for some reason ends up being in a deconditioned state. This was the graph from that study. So this is just resistance training. So you can see this little gray spot here. This is the percentage of people who were in remission for their sarcopenia. So at the end of the exercise, some people had had remission, which is amazing. But then as we deconditioned them, they ended up right back where they were when they started, if they just did resistance training alone, right? If they did protein alone, they obviously had been deficient prior to this study because they also benefited just from protein. But again, the benefits were lost at 24 weeks when they took it all away. The group that was given both, so resistance training plus protein, they actually, not as many of them actually regressed. And so they maintained the benefit of the training post 24 weeks of washing out all of the treatments. So it was interesting, right? And I think when we think about using leucine, it's probably stopping muscle loss, right? Like if we look at all the other studies on leucine, and of course I didn't list all of them here, there's a loss of, like, it's preventing the loss of muscle tissue in certain groups of individuals. And I think when we think about this aging population, this is a group that would probably benefit from us stopping muscle loss, especially if their exercise regime has to change or something changes about their life and they're not able to do their full plan that you have prescribed them on. There's other research looking at leucine in a calorie deficit, and I will be quite curious if we see some benefit in using specific leucine supplementation on patients on GLP-1s. It's not there yet, but I put this in here for food for thought, that perhaps when patients are in a calorie deficit, that there is a benefit for adding leucine in. And we do think that it almost becomes maybe conditionally essential above a certain age because it's difficult for the elderly to meet their needs as their metabolic, like as their metabolism in their muscles changes with age, right? So we need a certain dose of leucine to maintain good muscle anabolism when we're in our 20s. The need goes up with age, but we may not be able to fill that gap well with diet. And so there's curiosity if that's, it becomes conditionally essential later in life. And so there's some food for thought for adding those essential amino acids. I will say that the conversation around HMB is very similar. So HMB is a leucine derivative. We think it's beneficial under the same circumstances. So we see functional gains when we use HMB in the elderly who have sarcopenia. And we also think that it may be conditionally essential as we age because our ability to keep up with the demands that muscle have as we age start to decline. And so this may be one of those ones that certain groups of people benefit from because they have this gap in the amount of leucine or protein that they can take in versus the amount that their muscle actually requires for good function. Most of the studies on HMB use about 3 grams per day. HMB does not taste very good. I'm just going to put that out there. If you have trouble with compliance with your patients, it doesn't taste very good. And it might be one of those ones that we want to use capsules, even though that's a lot of capsules to hit 3 grams. But interestingly, this was another study that was kind of looking at disuse, right? So they were trying to use resistance training and HMB and comparing it against exercise alone. And they didn't see a tremendous benefit. But then when they compared it against like no exercise and that withdrawal of exercise, the HMB group actually performed much, much better than the other groups. So again, hopefully you can see I'm trying to weave you this picture here that you're underfed from a protein perspective. Patients benefit a lot from protein, from leucine, from HMB because they have a nutritional gap, right? When we meet them. We also have patients with disuse, right? So it's like the less exercise they do, there's maybe more room for benefit from nutritional intervention that's going to target that. And then when we talk about fish oil, that's going to have a very similar theme that the protein deficient and the exercise deficient patients benefit the most from fish oil for their sarcopenia. So I've been following this research on fish oil for so long, fish oil and muscle mass, and I left a slide in that showcases some of that older literature, which I know maybe we should eventually do away with that older literature, but I'm from McMaster University in Hamilton, Ontario, and they had a massive research team looking at fish oil and muscle atrophy. They would put like casts on people's calves and give them fish oil and not fish oil. And one of the researchers from McMaster, his name's Chris McGlory, I read every single thing this guy published for 10 years. I just thought their research was brilliant. They were looking at fish oil from so many different perspectives, and they actually are some of the OGs when it comes to looking at muscle mass and fish oil. So I have to give super props to my hometown university. Fish oil does not increase muscle mass across the board. Okay, you'll still see some papers that do not show an improvement in muscle mass. There's likely some subgroups that benefit more than others, and hopefully we learn more about that with time. There's also curiosity around dosing with fish oil, right? If we're meeting the right dose with people, and I do talk a little bit about the omega-3 index as a test in this section, but it takes a long time for people to change their omega-3 status. And we might be looking too early at some of these changes because it probably takes 6 months or longer for people to increase their fish oil status. That's going to be enough that actually impacts their muscle mass. But we do see improvement, okay? So there's improvement in muscle function. And a lot of the functional tests, when we add fish oil into this population, they do see improvement. I made this small note here, and this note maybe could have been earlier, that when you're looking at research and papers on sarcopenia, sometimes we'll see these very, very small changes, like their hand grip strength went up by 2 pounds, right? And that maybe doesn't sound very exciting to us. We would like them to totally PR their hand grip strength. But interestingly, when we look at the research on sarcopenia, very small functional changes actually translate to very large decreases in frailty. So those couple of kilos on their grip strength with their fish oil actually turns into a very clinically meaningful change down the road, right? And we know this. We know there's a big connection between these they feel silly, right? The sit stand test and the timed get up and go test and the grip strength. They don't seem that practical, these tests, and yet they translate beautifully to independence and frailty and falls and all the other things that we're trying to track in patients. So I do want to call that out. Funnily, like in practice, when I was practicing, I never tested omega-3 index, which feels like the walk of shame presenting here for Arupa. But it was not an easily accessible test for me practicing in Canada. And I really like those clinically meaningful numbers. And this one seemed like a more optimized population was interested in omega-3 index and maybe not my average Joe population, which is who I worked with. And yet all the research on sarcopenia does use omega-3 index as a benchmark for testing omega-3 status. So I'm going to give props to that test. And maybe this is a time that we would consider using an omega-3 index and shooting for a goal of over 8%. That does seem to be the cutoff where we're considering patients below that to be omega-3 deficient, specifically when it comes to muscle mass. We also have to be curious with fish oil that the length of supplementation probably needs to be quite long, especially in patients who are below 4% at baseline. So if you test your patient and their omega-3 status is like 3%, we might need to supplement them more than 6 months for us to see a significant change in their muscle due to the fish oil. So don't give up early. I think that's my take home with this one. Don't give up early. We probably need longer trials and we probably need longer observation with our patients. So this is one study that was observational. They noticed that there was a big difference between dietary polyunsaturated fatty intake and sarcopenia and muscle function. They did test in this study. They didn't see a great correlation with the testing, but it was a really interesting thing because they actually started to see that protein deficient patients are maybe the ones that respond the best to fish oil. And so I think that that's a really important piece as we start to look at some of the other studies, is that patients who don't eat enough protein benefit the most from fish oil. And that's a connection that's hard to make, right? Like, why would that be? But the patients that have the lowest protein intake at baseline are the ones that benefit the most from fish oil. So you may be able to see a case there why you would start someone on fish oil for their sarcopenia as you worked them up my little ugly arrow there of protein intake and resistance training. Do they need to be on fish oil forever and ever? Maybe. But where the greatest room and the greatest magnitude of benefit comes in is when they are still below the recommended protein intake. Okay, so hopefully you can see that connection there. This was another study that was looking, and they actually found a bit of a dose response relationship. So for every gram of fish oil they took, there was improvement. Most of the studies hang out around 4 grams, which I know that's kind of in that upper limit when we start to think about other things like atrial fibrillation and whatnot. But most of the studies looking at muscle mass do hang out in that 4 gram per day range, divided between like lunch and dinner. This was another one that, again, this is showing very clearly the people that were below 0.8 grams per kilo per day are the ones that benefited the most from fish oil. Okay, as soon as they were eating enough protein, they really didn't see a significant benefit from the fish oil. And this last study that I have on the page there is the one that really started to call out that we're likely not giving it to people long enough, that we need 6 months in order for us to see the benefit of people taking fish oil. So when we combine that with the earlier study around omega-3 index and how to get people above 8%, we're talking 6 months of supplementation with a moderately high dose in order for us to have this impact that we're looking at. So here's my friend, Chris McGlory, right? You can see he's published a lot of the original articles on this. They actually were doing this during periods of disuse. So it's another use case for fish oil. When we give fish oil to people who are on bed rest, people who are having surgery and have periods of disuse of their muscle tissue, they preserve their muscle mass better when they're on fish oil versus when they're on placebo. So that trend across all the things we've talked about today, it's like, if you're low protein, you need the supplements. If you're not using your muscles, you need the supplements. Okay. If you're doing everything perfectly, then maybe we don't need to consider supplementation because you maybe are already optimized. But there are some very specific cases where the supplements make a big difference to supporting. I did put some of the mechanism of actions here, and this is really fascinating because we always imagine that fish oil is working specifically because of the anti-inflammatory effect. It doesn't seem like that's the only reason that it's for how it's working with muscle tissue, because it's not lowering the vast majority of cytokines or inflammatory markers in muscle tissue. It seems to be working by other mechanisms, but we haven't quite sorted that out quite yet. But I did put those mechanism of action studies in there for you. For those of you that really enjoy that side of what we do in medicine, I did put them in there for you, but it is not strictly an anti-inflammatory effect, which I think is really important to consider, because we don't want to inadvertently be using CRP or any other marker of inflammation as a sign if people need fish oil, because it's not about inflammation when it comes to talking specifically about muscle loss. Okay, this was another one where they added fish oil capsules to women that were undergoing resistance training exercises. This was 4 grams per day. It was a mixed EPA-DHA product. And we saw big changes in the group that had added the fish oil on top of their resistance training. And this was quite a short study, actually. They saw improvement after 14 weeks. I love studies that are under 16 weeks, because that gives us so much hope that we can change the way people feel in such a short period of time. This was another one of those studies where there was no change in cytokines, no change in inflammatory markers. So sort of adding to our thoughts about this. This paper, just being mindful of our time, this paper calls out kind of an interesting piece when we talk about muscle mass and function. Who has ever had a really bad sleep and then a really bad day in the gym, right? Or you've kind of overdid it on the weekend and you come back to the gym on Monday and you're supposed to do squats and you feel like a trash bag and you can't actually do it, right? Ever? Anybody? No? Bueller? So this study was going on to say, is there intra-individual variability in exercise performance that is influencing the way we feel about fish oil? And it's a very long-winded way of saying, when you're in clinical practice and your patient, we're using exercise-based outcomes for your patient, we have to remember that there is a lot of intra-participant variability day to day in how they perform. So I caution you around using things like 1 rep max as your metric for success, because if they have a bad sleep, they have a bad lift. So I think, and this is where I would love research to go, and it's going in that direction when it comes to nutrition, is can we figure out who benefits most? Can we figure out how to individualize this care unique to that person? Right? That's what we all want. That's what this aspirational way that we deliver care is, that it's very individualized. In this moment, we don't have any reason to give or not give fish oil beyond the reasons I've already shared. Okay. We can't individualize their fish oil any more than 4 grams. If they're under on their protein, definitely. If they're under on their exercise, yes. We don't know any more than that. But I found this study curious because it was basically calling out that we have to be very careful when we're using exercise-based performance to mark success, because if patients don't sleep well, then they don't perform well, and then it ruins our whole study. This was another one that actually backed up a little bit and just looked at chronic disease in general and muscle loss. I spent a lot of time going down the fish oil cachex rabbit hole a few years ago, and it's really talking about this, that patients who have the biggest impact on lean body mass are the ones who have low baseline protein intake and also have underlying metabolic disease. And so I wanted to put that one there for you because it was quite recent. So where fish oil seems to make the biggest difference to improve muscle protein synthesis is low baseline status and disuse. Again, there may be a little bit of a dose-response relationship with it, but in general, we're thinking it's around 4 grams per day if we average it through all the studies. There's, unfortunately, for sarcopenia, there's only one paper that uses plant-based fatty acids, and it did not show benefit. I can't speak to some of those other options because there is no research on them. So they're all on EPA. So unfortunately, in this moment, this is where we live when it comes to the fatty acids. And then creatine, it's funny, creatine is having its moment, I will say. I presented it in 2021 as celebrities to watch, essentially. And at that time, the research was really underwhelming. There was not a lot of data for this population specifically, okay? We've studied creatine since the beginning of time. There wasn't a lot on the elderly and in patients with disuse and sarcopenia until recently, okay? And I do want to call out that the European Food and Safety Authority has just published a huge position paper on creatine, and they basically have considered it to be a mandatory part of nutrition at a dose of 3 grams. And I think we sit back and we go like, well, of course, right? Like, duh. It's a big deal, right? The amount of literature that needs to be available for a government body to make a strong stance like this is really significant. So if you're not prescribing creatine in your practice right now, please go read this position paper on creatine and let's get to prescribing. Okay, so we've got some more recent data here. Darren Kando is like the person when it comes to creatine research. They've looked at it from a few different angles in this sarcopenia population. We definitely recommend it to be combined with resistance training. It's curious whether or not we have a substantial benefit in people who aren't exercising. The vast majority of the research is in people who are doing resistance training, and it does improve the impact of that exercise. So here is our summary. We're doing great on time. Okay, so protein, and you're going to say this all with me so that you remember this when you go back to practice later this afternoon. So protein, we're at a minimum of 1.2 grams per kilo per day. And then I say with adequate leucine, okay? So our goals would be that we're also hitting a bit of a leucine adequacy. We used to say 2 grams per day. Most of those interventional trials were using a bit more than that, but our kind of basic needs would be around 2 grams below that, and we would be considered to be deficient. We're going to consider leucine as a standalone supplement, like as we're adding it to our protein in patients with low baseline protein intake while we help them increase their nutrition habits, but also in patients with disuse. I gave you that sort of use case. If patients are going to be inactive for 24 weeks, we may get the biggest bang for our buck if we add leucine to their regime while they're exercising. So their period of disuse, they don't have as much muscle tissue loss. We talked about HMB with 3 grams per day. Again, we're talking about disuse and protein deficiency. My guess is the first 12 to 16 weeks you work with all your patients, they're still protein deficient as they change or learn to change. So this would be a great opportunity for you to support those patients to support their muscles. Fish oil, we see improving muscle mass in patients with low baseline status. Lots of use case for disuse or injury when patients are bedridden or unable to exercise. 4,000 milligrams per day as our dose. And we do see it when it's eaten in the diet, so unsupplemented, but high polyunsaturated fats in the diet, we do see improvement in muscle mass and function observationally. So, if your patients arrive at you and they eat well, they have protein adequacy, and they eat enough fish, perhaps we don't need to supplement them. But this is one of those curiosity points where do we test patients, right? And try and find out their omega-3 index and use that as our decision maker. And then creatine, I gave you a slightly wider dose range there, but 3 to 5 grams per day in all patients. Regardless of who you are, we're benefiting from adding the creatine to the resistance training. And so that would really be a great one to use universally, regardless of the person's baseline protein status. So I hope that you feel inspired that we can do a lot here. Really, we need an army of practitioners, I say, who are confident and capable to see sarcopenia coming a decade away. I hope you can see now at the beginning of the presentation when I changed our strategy for screening that we're going to have earlier conversations with our patients about protein adequacy and polyunsaturated fats and resistance training so that we catch up to this idea. We know sarcopenia is happening a decade before we find it. Let's do something about it a decade before it happens. And you guys are definitely the behavior change specialists. And so hopefully you feel empowered to do something positive with this information and take it back to your patients.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Ruba Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.